and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And to present today's topic, I welcome Dr. Hitesh Verma. Welcome, sir. Over to you.
Thank you. Uh, Good evening, everyone. Myself, Dr. Hitesh. I am working as additional professor in Department of ENT, NBEMS, New Delhi. And today's topic is recurrent respiratory papillomatosis. So, by the term, you already know it's a recurrent disease, and it comes in papilloma form and involves a respiratory airway. So, normal prevalence for human papilloma virus in larynx is approximately 5%. So how papilloma is present, it's a warty growth of airway. It can involve from nose to lungs, any part, but mostly it involves laryngeal part. So human papilloma virus is a causative organism for it. Around 180 strains were identified over a period of time. Out of them, 611 is the most commonly found, uh, and 618 is less commonly found, but it is more associated with malignant transformation. The 611 is more associated with repeated disease and worsening of disease. So it is generally acquired from infected mother by vertical transmission or by the sexual contact, abnormal sexual contact. So this is one of the picture where the papillomas involving the vestibule. This is another picture where the papillomas involving the glottis. This is a vocal, these are the vocal cords, and this is a papilloma. Here we can see this patient underwent tracheostomy for papillomatosis, and what we can find is a papilloma involved at the level of the tracheostomy site. And in this video, we can see this is a vocal cord papilloma, and subsequently it papilloma at the level of the tracheostomy tube site. And once it's removed, it involves the lower part of the trachea. And here in the last part, we can see this is a carina region, and some amount of papillomas are present at the level of carina also. So respiratory papillomatosis generally have bimodal age distribution, juvenile onset and adult onset. So JO-RRP is juvenile onset recurrent respiratory papillomatosis, and AO-RRP is adult onset recurrent respiratory papillomatosis. Another, in few articles, it's mentioned as juvenile continue in the adult form. So progression of juvenile disease into the adulthood, that can be possible. So recurrent respiratory papillomatosis is most common benign lesion of childhood, and it affects mostly under the age of 5 years. So disease course is unpredictable. It can range from spontaneous remission of disease to aggressive, persistent, recurrent, or even malignant transformation of the disease. So etiology, I already told you, human papilloma virus is responsible for these papillomas. It is a Papuaviridian family, non-capsulated, naked virus. It's a capsid virus and it has double standard DNA. This part is, I already told you, around 200 subtypes were identified. And 611 is more commonly involved in respiratory papillomatosis, even the genital papillomatosis also. This 11 is more aggressive form as compared to the 6, type 6. With the 16 and 18 is mostly associated with the carcinoma. So if we identified patient is suffering from 16 or 18 strain, there's a risk of malignant transformation. So rigorous follow-up is required in such kind of cases. So this is a human papilloma virus strain. There are around 7 different type of proteins are formed in this by this DNA. E6 and E7 is primarily oncoproteins, which are which suppress the P53 gene and which can lead to papilloma growth over a period of time. So what is the pathogenesis? When the virus enters the traumatized epithelium, it resides within the basement membrane of the mucous membrane, and it replicates by the episomal maintenance, in which virus interferes normal process of cell mutation and causes epithelial proliferation and neovascularization. That is appear in the form of papillomas. Like in this picture, we can see papillomas. In histology, it is a mucosal proliferation, and as a result of multiple finger projection, we can see, like in this picture, we can see here there's a multiple finger-like projection with central stoma. This is a seen in the case of respiratory papillomatosis, where the epithelium seems to be okay, but is a papillomatous growth seen underlying to it. So eruption of papilloma in the airway, which are histologically stratified squamous epithelium covered by vascular projection and vascular growth, is essential for papilloma proliferation and distal migration. So transmission, so it is associated with human papilloma virus infection in mother. So majority of the cases vertical transmission during the delivery, mainly vaginal delivery, and minor one include maybe infection can involve in utero, through the placenta, maybe sexual abuse, or because of direct contact. So usually most common symptom is most common site of involvement are larynx, and in larynx, glottis is the most common site. Then most common way of presentation is a hoarseness, because any lesion involves a vocal cord generally present with a hoarseness. As the lesion increase in size, it can compromise the airway, and patient can present with a stridor. It begins with inspiratory stridor because supraglottic and glottic lesion generally present with inspiratory stridor. As the disease progresses to subglottis, trachea, or in other part, then stridor can vary, maybe biphasic, or maybe involve both part also. So waxing and weaning of the clinical course of remission and exacerbation is common, which I already told you. So other presenting symptoms are chronic cough, recurrent lower respiratory tract infection, pneumonia, failure to thrive, especially in young children, dyspnea, dysphagia. Dyspnea when it's confined to the airway, dysphagia when it involves the hypopharynx or oropharyngeal part, then it can be present in the form of, can present dysphagia, or because of repeated surgery, scarring can happen, and that can also present with dysphagia. Or sometimes in young children, there may be acute life-threatening event also. So other most common site for extralaryngeal spread are oral cavity, trachea, and bronchus. So tracheobronchial involvement can lead to recurrent pneumonia, lung abscess, and lung collapse. And there are 3 to 5% risk of malignant transformation. And tracheobronchial dissemination is associated with higher risk of malignant transformation of the disease. So malignant degeneration is rare and devastating sequence of this RRP. It's generally fatal because it's very difficult to irradiate or even providing chemotherapy to tackle this much extended area, right from the larynx till the bronchus. It's very difficult to manage. So who are at high risk of malignant degeneration? Young age of onset, those with tracheal involvement, or those infected with human papilloma virus type 11. 16 and 8, because 11 is associated with worst form of disease and recurrent relapse. So because recurrent relapse can lead to the epithelial changes, and which can lead to malignant transformation. And conversion of malignancy is more common in 16 to 18. But when studies are performed, human papilloma virus is more commonly involved with recurrent disease. So that's why it's associated more with the malignant degeneration. Or prior history of irradiation of papillomas, then there is a risk. Another risk factor are tobacco use, persistent gastroesophageal reflux disease can worsen the disease and can lead to malignant transformation. Or sometimes long-standing disease can lead to malignant transformation. So mechanism of malignant transformation, which I already told you, E6 and E7 oncoproteins, which inactivate P53 and PRBG, results in loss of control over proliferation and cell division. So malignant transformation in adult mostly seen in the laryngeal part, but whereas in children mostly seen in the bronchopulmonary tree area. So staging was described by Durkee. Left hand side we can mention the symptoms, how much, what is the duration of voice change, what is the duration of stridor, and all that. This is basically we are following this one. Durkee divided different subsites of larynx, trachea, and other parts. So it's total, it's around 25 subsites. And for each subsite, we can document the papillomas. 0 means none. 1 is when there is a surface elevation, 2 is when there is a raised lesion, and 3 when there is a bulky lesion. So 25 subsites, so maximum score will be 75. So this is a picture when there is score 0, there is no elevation. This is a 1 when there is a raised lesion, and this is a bulky lesion, score 3. This is again here in this video, we can see this is a raised lesion. It's a two different subsites can have different level of proliferation. Like here, we can see type 3 in these areas, just a raised lesion. It's a type 1. Here again, type 3. So aggressive variant, early age of onset, type 11. And literature shows it's a primarily in the low socioeconomic group disease. So it can lead, because of poor hygiene and all that can lead to, and poor education status, that can lead to a worse form of disease and even the recurrent form. So literature also suggests there is a lack of heavy metals can lead to worse form of disease. So this is one of the article where they suggest zinc, when prescribing zinc as an adjuvant therapy, so it can be reduce the severity of disease. But this study we have done at TEAMS, where all trace elements were evaluated during the 2016 to 2019 period in 37 patients. So 2 metals were identified. One is arsenic, which is 0.0, p-value was 0.012%, and other one is thallium. But when we compare it with clinical outcome like age of onset, number of surgical procedure, total anatomical Durkee score, presence of tracheostomy and histopathology, different heavy metals shows p-value with different parameter. None of the heavy metals shows correlation with all the parameters. So the study was not significant, no significant value was identified during the study. Next comes the radiology. As such, respiratory papillomatosis is a clinical diagnosis, which is supplemented by the histopathology. So radiology is not required, but if we find in young age disease is involving the upper part, in that case, X-ray is sufficient to assess the lower airway. But when the disease is extending involving the lower trachea, bronchus, then CT scan is required to know the extent of the disease and to know the response of the treatment. So treatment modality is divided into preventive measure and therapeutic measure. In preventive measure, there is a human papillomavirus vaccines comes into market, Cervivax, which is a 2 variants were used in this vaccine, 16 and 18. Then comes a Gardasil, 4 variants, 6, 11, 16 and 18. Then again 9-valent vaccine, which includes 6, 11, 16, 18, 31, 33, 45, 52, and 58 subtype of strains. So dose is 0.1 ml per dose intramuscular. Dosing schedule 0, 1, and 6 for bivalent, and for 4-valent and quadrivalent 0, 2, and 6. So it is, the drug is prescribed above, this vaccine is advisable above the 9 year of age. So what it is ideally suitable for young boys and girls from 9 year of age prior to become the sexually active. So Australia was the first nation to introduce its nationwide government-funded vaccine program. So limitation for this vaccine is a high cost and availability, and vaccine can promote unprotected sexual activity and may lead to acquisition of other STDs and limited protection from oncogenic types. And continuous screening is even though required even after vaccine also. There's a risk of local infection can be there. So after once they introduce as a national program, they could identify there is a decrease in the number of incidence and prevalence rate of human papillomavirus infection. Then comes the therapeutic measure. Secondary once the infection is there. So what are the principles? We should convey the patient up-to-date literature regarding human papillomavirus to RRP patient. There is no definitive cure till date. No single modality of treatment is available. So our aim is to reduce the airway tumor burden and to increase the time interval in between the procedure to provide optimized voice quality and to stag papillomas removed from the tumor involving the anterior commissure. The anterior commissure lesion should be staged because there is a risk of scarring and anterior glottic web formation, which can lead to voice change. So it should be staged so that both sides will not be injured on same time and the risk of scarring will be less. And to prevent the complication of subglottic, glottic stenosis and web formation. So objective of surgery is to provide adequate airway and patency. Excessive excision of papilloma should be avoided. It, as the literature suggests, it does not reduce the risk of recurrence, but it can increase the risk of mucosal injury and subsequent scarring. So aggressive resection is especially contraindicated when it is involving anterior and posterior commissure because of scarring. And tracheostomy should be avoided because it can lead to rapid colonization and distress spreading. Or if patient came with respiratory distress where the management is not possible without tracheostomy, so patient should be decannulated as soon as possible. So to prevent the risk of distal spreading. So surgery, at present, surgery is the mainstay of treatment because patient usually present late in our continent and with respiratory distress and voice change. So surgery provides immediate airway as compared to medical treatment, and medical treatment is costly and repeated treatment is required. So in surgery, we can use either cold instrument or maybe laser or maybe microdebrider or coagulator. So this is one of the video where the cold instrument, this is a microforceps which is used to remove the papillomas. This is a laser. Here the papillomas are confined till the level of the vocal cord. So laser was used in this case to remove the papilloma. So two type of laser can be applied, CO2 laser or KTP laser. So depending upon the availability of the laser, different authors use different kind of laser. Next come the microdebrider. So below the vocal cord, it's very difficult to do with cold steel instruments or even with laser. So below the vocal cord lesion, microdebrider is a good tool, or even the coagulator is also a good tool to manage such area. So this is another article which is published from NBEMS. Here we showed the surgical challenges during the removal of papilloma. So what we conclude, CO2 laser is a good tool for supraglottic and glottic region. For subglottic, tracheal, or even early bronchial lesion, microdebrider is a good tool, as it is because anesthetist and surgeon both are sharing same airway. So generally, when the disease is involving lower part of the airway, in such cases, repeated apnea is given in between this debridement. So how because tube is coming in, if patient is not tracheostomy, in that case, if tube is there, it's very difficult to manage very difficult to remove the lesion with the tube. So the tube is removed, and then papillomas were managed. And once the desaturation occurred in monitor, then tube was reinserted. Then again, oxygen saturation maintained. Then again, tube can remove, and then again debridement done. So microdebrider is a good tool as we can remove number of papillomas in a short period of time, and it has inbuilt irrigation and suction, so it is also helpful. And diode fiber laser can be used in the subglottic area, but it is very soft, so it's very tricky to manage. And when there is a multiple lesion, it's very difficult to manage And with the apnea, recurrent apnea, it's very difficult to manage. So this is one of the picture. What we did from above, this is a oral cavity and this is a direct laryngoscope. So from the direct laryngoscope, endoscope was introduced, and from here the tracheostomy tube was removed. The endotracheal tube was removed. Then tumor handling was done through the stoma. Microdebrider was placed through the stoma because this airway length is quite long and it's very difficult to manage the even microdebrider from the upper part, and it is relatively easy if stoma is there and disease involving the lower areas. Another newer modality of diagnosing the extent of the disease is a narrowband imaging. So it is helpful in demarcating the disease extent, and more effective papilloma removal can be done with CO2 laser ablation or even microdebrider. But disadvantage, once a bleeding is occur, it's very difficult to uh, demarcate the lesion. So it is good tool for diagnostic purpose and to define the boundaries when there is a single or even few lesion. If there is a multiple lesion, then it's very difficult to demarcate each lesion with the narrowband imaging. So if it is disease confined to supraglottis and glottis, it's a good tool to assess the disease extent. And again, this is a data was collected from 2016 to 19 period at teams, and what we find is a majority of patients were lied at around the age of 5 years. As the age increased, few patients we could identify. So primarily juvenile onset and less commonly adult onset we have seen in our experience. So male patients were 21 and female were 60. So male predominant, it was seen more in male predominant, more male predominant. What literature says for juvenile onset, it's almost equal in male and female. For adult onset, it's more common in male. So in our study, we have both kind of patients. So male was found predominantly. So as the patient who have recurrent disease must have long follow-up as compared to who are completely cured. So here we can see even 42 years of follow-up. The patient underwent somewhere 177 surgeries over a 40-year period. As compared to the patients who were managed early stage of disease, the follow-up was relatively less. Here, few patients were some close to 20 surgeries. Here, this is a follow-up around 35, 80 surgeries are done with 35 years of follow-up. Sorry, it's hang little bit.
Yes, sir. Any issues, sir?
Oh, actually, cursor is hanged.
Okay,
Wait a
just
minute.
click once on the presentation.
So what literature suggests, old literature suggests, it's primarily involving the low economic status. But what we found in our study, according to the modified Kuposomi scale, majority of patients were lying in the upper strata and upper middle strata, less commonly seen in the lower strata. So it was not confined to lower strata also. In our scenario, can involve upper and middle also. So gastroesophageal reflux disease, as the symptoms are almost similar. Both diseases can involve the airway and hypopharynx. So in that case, symptoms are almost same: dry cough, sudden increase in saliva, hoarseness, chest pain, asthma. So it's very difficult to differentiate these two. But what literature suggests, the prevalence of gastroesophageal reflux disease in RRP is around 0 to 71%. Or even in our study, what we found is around 43.2%. So what are the drawbacks of repeated surgery? Here we can see complete scarring of anterior glottis. And there's a minimum opening seen in the posterior part of the glottis. So web forming, adhesion, scarring is the drawback of repeated surgery. So next comes the adjuvant therapy. So when adjuvant therapy, it is indicated approximately in 20% cases of RRP. When it is indicated when 3 to 4 times, when the surgery is required more than 3 to 4 times per year. In such cases, and when the disease is not amenable with resection, like for example, if it is involving lower trachea and bronchus, in that case, it's very difficult to remove such kind of disease. And when there is an aggressive form of disease, it's continuously increasing in size, even though we are operating at less, but we are suspecting it is worsening. In that case, adjuvant therapy is indicated. So adjuvant therapy is worked by immune modulation, disruption of human papillomavirus replication, control of inflammation, and prevention of angiogenesis. So what are the drugs in antiviral therapy? Can be interferon alpha, cidofovir, acyclovir, ribavesine. Other is a photodynamic therapy. Other is indole 3 carbinol, anti-reflux therapy, and latest one is a bevacizumab. One is vaccination also. Vaccine is helpful in preventing the disease, but vaccine is also helpful in increasing the interval of the disease. Anyhow, none of the treatment provides 100% success. So different modalities were tried over a period of time. Still, there is no single modality is available for this. So first one is interferon. First systemic therapy was given was interferon. So interferon acts by it is an antiviral therapy. So outcome was what noticed around 12 months of follow-up, 67 to 77%, complete or partial response. So still there is around 30 to 40% of patients who are not responded with this treatment, and this is associated with long list of side effects like mental disturbances, neurological disorder, thrombocytopenia, leukopenia, hair loss, and fever. It is less commonly used as an intralesional adjuvant therapy for local and systemic uses. Next therapy was a photodynamic therapy. It is almost shows similar result, but study was follow-up period was quite small, 4 weeks. So in 4 weeks they said it's a complete regression of disease. So, but recurrent relapse is common. So long-term follow-up is required for any treatment modality to establish as a treatment modality, any treatment. Next comes the intralesional therapy after systemic therapy, cidofovir. Cidofovir, it can be given in the form of intralesional or even in the inhalational form, nebulization form. So it is also antiviral therapy, which inhibits the growth, and outcome was 75 to 89% response. So it is also associated with nephrotoxicity, hepatitis, and neutropenia. Initial study showed it can lead to malignant transformation of disease, but over subsequent studies not supporting that article. So even though now is in the use, so outcome is around 75 to 89%. Then the latest most commonly followed drug is a bevacizumab. So this is a video where the intralesional bevacizumab is given. But when the disease is very extensive, it is good. Intralesional injection is good for single or twice or thrice lesion. But when there's a number of lesion is available and it's very difficult to inject in all the lesion base, in such cases, systemic therapy is required. But outcome of systemic therapy, systemic bevacizumab is questionable. Outcome is around 58 to 95%. But what literature shows, it is also a short-term follow-up. How bevacizumab act? It is a recombinant monoclonal antibody against a vascular endothelial growth factor. So it is found within this histopathological picture I showed you, where the vascular stroma was there and neovascularization occurs. So VEGF level is raised when there is a papilloma. So this drug targeted on this elevated VEGF level, so inhibits the growth or even regression of disease. It's a relatively rare disease. That's why prospective trials is not possible. So this is the latest article which is published in Laryngoscope, where the consensus was created among the surgeons. So what are the conditions where this drug is indicated? So if patient characteristic, for example, if difficult to enable, like very young age, patient is not fit for general anesthesia, in such cases, bevacizumab can be given. Disease characteristic, when there is a 3 to 4, more than 3 to 4 surgery, when there is extensive disease. Another acceptable is a treatment center characterization. Sometimes few centers doing some academic work and some clinical studies, in that case it is advisable. And patient was already given previously bevacizumab, showed good response, and patient accepted that treatment, then again can be given. So on the basis of these studies, this is another study which we did at NBEMS, where the serum and tissue expression of vascular endothelial growth factors were evaluated. As the RRP is a non-invasive disease, so how vascular endothelial systemic therapy helpful in treating such lesion? It's not invading the underlying basement membrane. Then comes patients who are likely to benefit, because what consensus or even previous literature suggests, same group of patients where the other drugs were given and outcome is variable. So primarily two conditions where the systemic therapy is advisable. One is 3 to 4 surgery more than per year, more than that, or when there is extensive involvement. So the aim of the study to identify the role of VEGF in the pathogenesis of RRP by analyzing the tissue expression and serum level of VEGF-A level among the RRP patients and compare with the disease characteristic. In between 2016 to 19, diagnostic criteria is same, detailed history, then clinical examination, if required radiology, and the serum sample were sent for serum VEGF evaluation, and papillomas which were removed surgically were sent for VEGF-A receptor evaluation. Inclusion criteria of those who underwent surgery and those who are willing to participate. Exclusion criteria, those who are not willing to participate, and those who are suffering from some other diseases which can raise this VEGF level. Then we compared it with prognostic factor like age of onset, number of surgeries, disease extent, total Durkee score, and tracheostomy status. So total 32 patients were included during that period. Age range was 3 to 60, and glottis was found involved in all the cases. At the previous literature suggests glottis is the most common site, and tracheobronchial involvement was found in 6 cases. Here, when the Durkee score was less than 20, around 21 patients, and Durkee score was more than 20, was seen in 11 patients. So tracheostomy was found in 13 patients. All the patients were tracheostomized from outside, and then they referred to us. So none of the tracheostomy was performed at our center. And tracheobronchial involvement was already told you. And the number of surgeries, those who underwent less than 3 times, 19 patients, and those who were more than 3 times, 13 patients. So mean serum level in a study group, which is 32 patients, VEGF level was found higher as compared to the control group. That means it's suggestive of there is even though disease is not invasive, but systemic VEGF value is raised. Then tissue was assessed, Out of them, 11 patients shows no tissue expression of VEGF, 12 shows weak expression, and 9 shows strong expression. But where in the control group, there's a expression was weak in only one patient, rest were the control group were negative. So both serum and tissue value was high in disease group as compared to the control group. Next, we compare, this is again same disease group and control group. Next, we compare with the various parameter, total disease extent, tracheostomy status, and tracheobronchial involvement. So if Durkee score is high, in that case, serum VEGF value more than 40 if Durkee score, then it was found significant, and tracheobronchial involvement, when the disease tracheobronchial involvement is there, the p-value was found significant. So when we compare, when there is a high Durkee score, then the serum and tissue expression was increasing progressively. So there is a positive correlation among the disease extent and Durkee score. So what we concluded from the study, those who have higher systemic and local expression of VEGF in aggressive cases like tracheobronchial involvement, and those who have high Durkee score. Linear correlation was found in between expression of tissue and serum VEGF with disease extent. So we propose bevacizumab is a good therapy for those who have extensive disease, where the amenability of disease is not possible either with surgery or other form of medical management. Anyhow, in this study, treatment was not planned. So outcome of the what will be happen in such cases if bevacizumab will given. So will they match with the our finding or not? So after the study, out of these 6 patients, 4 patients received systemic therapy, 1 showed complete regression, and 3 patients are still under follow-up, and they are taking bevacizumab at regular interval. So this is a pre-treatment endoscopic finding where we can see papilloma, and this is after the administration of bevacizumab. So this drug is costly. Repeated for systemic therapy, repeated administration is required, maybe for 8 to 12 weeks interval. So it may be difficult in our scenario because cost is an issue. Other drugs are celecoxib, which is a COX-2 inhibitor, which also showed some amount of response, then tyrosine kinase inhibitor, then PD-1 inhibitor, Perbrolizumab. This is under trial. Another, this is a homeopathic drug which is available in our continent, Thuja, and it is also used for cutaneous and even genitalial warts. In one of the study, we did Thuja trial, and we found the outcome was not significant except the interval of disease was raised in between the surgery. So thank you.
Dear trainees, you may type your questions, comments in the chat box.
the broad group where the number of groups come under it to it. So specifically HLA may shows a number of disease it may show, but when we further divide, maybe few patient lies in one group and few lies in other groups. It's very difficult to show association with that. I don't think there is any study on that HLA association.
Any more questions, trainees?
Less, no, none of the literature shows because it absorbs simultaneously. Cutting and suctioning occur simultaneously. In laser, uh, hitting occur by laser at targeted lesion, and suction is at far distance from the laser. So in that case, aerosolization was documented. But for microdebrider, aerosolization was not documented anywhere. Maintenance therapy is none of the therapy show because all the therapies either give in injectable form. You can give if there is a gastroesophageal reflux diseases, if you can identify in such cases, you can give anti-reflux measure or maybe celecoxib and COX-2 inhibitor or maybe thuja. As there is a none of the treatment shows complete response, so it's very difficult to tell which treatment will be helpful in that particular patient. So it's more commonly individualized according to the clinical finding and your assessment. So maintenance, as such, no maintenance therapy is advisable.
I think no more questions, Dr. Hitesh. Thank you very much for the presentation, and thank you very much, trainees, for joining us.
Thank you.